Доброго вечора, українські радіаційні онкологи. Слава Україні! Дуже дякуємо, що приєдналися до Case Review with ASTRO Experts for Ukraine. Today we have a session on gynecological cancers treated with external beam radiotherapy. In this case review series, we have two sessions dedicated to GYN. One is using external beam, that's today, and the next month we'll have a brachytherapy dedicated session. So we have two great speakers today. First speaker is Dr. Anuja Jhingran. She is a professor at MD Anderson. And the second speaker is Dr. Marina Sokolovska. She is associate professor at Shupik National Medical Academy for Postgraduate Education, and she's also a chair in radiation oncology at Lisod in Kyiv. So a little bit more about Dr. Jhingran. She earned her MD at Texas Tech University in 1988, followed by residency training at Baylor College of Medicine, Internal Medicine, and Radiation Oncology. She began her career as an assistant professor at the University of Texas MD Anderson Cancer Center in 1996 and has advanced to a professor of radiation oncology in the section of gynecology. She is a physician specializing in treatments of gynecologic cancers. Clinically, she is interested in management of advanced ovarian, cervical, and endometrial cancers and the use of advanced radiation techniques to minimize toxicity. In addition, Dr. Jhingran is heavily involved with RTOG and GOG in the development of patient care studies to treat GYN cancers in the national and she is also a national principal investigator of several accruing studies, including phase 3 study in cervical cancer. Dr. Jhingran travels extensively internationally for cancer education. She's very passionate about women's health issues, and especially as it relates to developing countries' effort to establish improved health care for general populace, not just financially able. And if you heard us chatting just before this introduction, she talked about various courses that she taught for in Africa. Thank you so much for your efforts, Dr. Jhingran, and thank you for supporting Ukraine today. Thank you for giving this lecture. We are really honored to have you here. And our second speaker does not really need an introduction for in between Ukrainians. She is a very well-known radiation oncologist and a leader of the field in Ukraine with more than 20 years of experience in modern radiation oncology. She is a chair of radiation oncology department in Lisod Hospital in Kyiv, and she's also associate professor, as I mentioned, at the Shupik National Medical Academy. She has been very active participant at various national conferences, organizing sessions in radiation oncology. We had just a recent session on COHAP Up to Date in Kyiv that she organized. So we're really grateful for your efforts, Dr. Sokolovska. She also has been organizing practical workshops, and one of the most recent ones was on head and neck cancer that was very successful. And with the help of Help Ukraine group, Dr. Sokolovska this year was able to do two observerships. One of them was at Miami Cancer Institute with ASTRO attendance, and another one was at Christie, Manchester, with ESTRO attendance. So welcome, Dr. Sokolovska. We're very happy to have you here. Always a pleasure. So we thank you very much, both of you, for preparing this lecture. I know you both are very busy, so we're looking forward to learning about GYN cancer treatments with external beam radiotherapy. Dr. Jhingran, the podium is yours.
Great. I'm hoping that you guys can hear me. My lecture is actually going to be a little bit focused on some of the questions that I got from Dr. Marina. So I'm letting you know that it's not, we try to focus it because it's so big. It's still going to be big, but we try to focus it. I try to focus it on the questions that she asked me. So hopefully we will learn something and you will let me know what questions you have. So GYN, external beam, big topic. Hopefully we will get through this because we have some great case discussions after this. So we're going to start with cervical cancer, but a lot of this is a little bit generic to all GYN tumors. But let's go back to cervical cancer. So what's the general initial exam? So it's got to be a focused physical exam. You need vitals, general experience, but the key is the pelvic exam. And it's really important when you do the pelvic exam, just really not just for cervix, for vulvar, vagina, or endometrial. You do need to look at the external genitalia, especially if it's vulvar cancer. You want to see where the lesion is, what it's involving. Then I always, no matter what, do first a digital exam, especially in patients that had previous radiation, because they could have scarring. But even patients who are early diagnosed, you don't know how much of the vagina is involved. So you can't just put the speculum in because you don't know how far the speculum will go. So I always do a finger exam first to see, one, if there's scarring, where the cancer is, how much of the vagina is involved, if any of the vagina is involved. Then I put actually the speculum in and evaluate the disease that's there initially and post-radiation as well. Then you can do a bimanual exam. A lot of times, even by 2 fingers in the vagina, you can tell if there's perimetrial involvement or sidewall disease, if it's fixed. But by doing a finger in the vagina and the rectum and sweeping it, you really can tell the size of the tumor and if there definitely is perimetrial or sidewall disease. But when you're doing all this, you really need to think about what you're feeling so you can document it in a diagram afterwards, because you really need to know what the cancer, what the disease and the diagnosis was initially, so you know what to treat once it's responded. So key: size, extent of vaginal involvement, extent of the disease. You want to know perimetrial involvement. You want to know sidewall disease. Key size is really important. So what do you do after you do the exam? If there's a visible lesion, you're going to biopsy. Then you can do a cystoscopy, a rectosigmoidoscopy. We usually do not do that. We will do chest x-ray. You can do a CT scan of the chest, abdomen, and pelvis. You will do labs. Labs are really important. They will point to you for hydronephrosis. They can tell you what the kidneys are functioning. And then depending on where you are, imaging. So one thing that we were going to talk about is what imaging should you do and why. So one, CT. You should do, for sure, if you can't do anything else, you should do a CT of the chest, abdomen, and pelvis to rule out metastatic disease, but you want to look at hydronephrosis and you want to look at lymph nodes. So that is the minimum for locally advanced cervical cancer that you really want to do for staging purposes. MRI, so for us, our standard is MRI and PET scan. MRI for local soft tissue extension to see if there's perimetrial involvement. We do, and this is important, our standard MRI protocol for the pelvis for all GYN tumor is we do put ultrasound jelly inside the vagina. And if you look at a T2, it comes up as a bright signal. But why is that important? It separates the vagina so that you can see the vaginal extension. You can see the full extension of the cervix. So all of our GYN patients, that's standard protocol to have ultrasound jelly put inside the vagina. But MRI, key for local soft tissue extension. It can show you nodes. I have to say CT scans better for abdominal nodes than the MRI is. And then, of course, PET scan. As we know, PET scan is probably the most sensitive on showing you positive nodes as well as distant metastases, especially in the lung. So our standard at MD Anderson is an MRI and a PET scan, but a CT scan is good and is a great way to do diagnosis. So let's talk about, again, GYN in general. What are the most common sites that GYN cancers go to? Lymph nodes, okay? And that's key. They do go to lymph nodes. So what are the most common lymph nodes? Parotid, common, presacral, internal, external, obturator, and inguinal. And I will go over this in a bit. But let's talk about differences in drainage. Cervical, vulvar, and vagina drain the same, okay? So in other words, they actually flow, all the way. So cervix will first go to your obturator or your external or internal iliac, or common. So they will go first to the pelvic nodes, and then it goes to the parotid nodes. If you see a positive parotid node, you know there's got to be some pelvic node somewhere, and you've got to look for it in cervical cancer. Cervical cancer will never go straight to the parotids without involving a pelvic node. Vagina is the same way, and vulvar is the same way. So for vulvar cancer, it will first go to the groins or the obturator before it actually goes to the pelvic nodes, and then it goes to the common and the parotids. So the difference of that is compared to uterine, uterine can go to the parotids without involving the pelvic nodes 20% of the time. So if there's fundal involvement, 20% of uterine cancers can involve the parotids without involving the pelvic nodes. That's important. That's the one big difference between uterine cancer and cervix, vagina, and vulvar. And this just shows you. So cervix is very symptomatic, systematic, where uterine is not. So this just shows you, right? So uterine, aortic, common iliac, internal iliac, external iliac. Endometrial does not go to presacral unless there's cervical involvement. So you do not need to include the presacral nodes in the endometrial cancer when you're doing external beam. Cervix, common iliac, external iliac, internal iliac, and presacrals first, and then it will go to the aortics. Vagina and vulva are the same, and we'll talk a little bit more about that as we go further. So, first question. What cancer can go directly to the parotid nodes without involving the pelvic nodes? I made it easy, but I wanted to make sure you guys are paying attention. And let
So,
me know
yeah,
if
we will wait until probably 85% answered, and then I will stop the poll.
and then again, let me know if I'm
Yeah.
talking too fast, because I
No,
can.
written is good.
Okay.
Excellent. Yeah. Need a few more answers, please. Okay. I'm ending the poll, sharing the results for everyone to see. Would you like to comment?
Yes, so as I mentioned, endometrial cancer is the right answer because that's the one that can go 20% of the time to the parotids without involving the pelvic nodes. And that is usually when there's big fundal involvement. And that's important because most of the time sentinel nodes for endometrial cancer is done by the cervix. So you inject the cervix. So you can 20% of the time miss a sentinel parotid node. So that's a possibility. So you just need to know that.
Mm-hmm. Thank you.
Thank you.
Stop sharing.
Okay, so the answer is endometrial cancer. Okay, so we're back to cervix cancer, right? Radiation therapy is the mainstay treatment for advanced cervix cancer. And these principles have been there since I started radiation oncology, I think since Marie Curie started radiation oncology, right? The principles are you need to include macroscopic and microscopic extension. That's why I started my lectures with the nodes, because we need to know where cervix or where endometrial goes so we know what to cover. Radiation dose is so important. And this has changed, but I'm going to go with the one that we used to know, 85 to 90 gray to point A. If you're doing HRCTV, you want an EQD2 of between 90 to 95 to point A. I am not going to go through those doses because that's going to be in the brachytherapy lecture. But, we have changed that a little bit, but it is important because I am going to talk about interlace. So we're going to talk about that in a minute anyway. Key, brachytherapy is the most important thing that you can do. So locally advanced cervical cancer is treated with external beam and brachytherapy. Studies have shown that if you don't do brachytherapy and you just do external beam, there's a decrease in local control and overall survival. So brachytherapy whenever possible, and it doesn't matter if it's intercavitary or interstitial or a combination of both, but brachytherapy is important and the key is you got to get it all done in 56 days. So let's talk about treatment planning, right? So I know you guys all know this, GTV, CTV, PTV, so I'm not going to go over it, but GTV is gross tumor volume, CTV is clinical target volume, and PTV is planning target volume. Key when you're thinking about GYN tumors, CTV is your microscopic disease, and that's really important. So how do we cover the nodes? And we just talked about what nodes to cover. We need to put a margin around the blood vessels because the nodes lie around the blood vessels. The lymphatics are parallel to our venous system. So parotics, we talked about parotics, right? So this is giving you examples of parotics. When you are treating the parotics, you want to put the arms up for simulation so that the arms are not going to be in your fields. What is the top of the parotics? It used to be the top of L2. We're gone away from bony landmarks. So I am not going to be talking about bony landmarks. The top to cover all the parotics is the top of the renal vessels. And that's key. So the top border for the parotics is the top of the renal vessels. But as you can see, as we're doing this, here are your vessels, right? So you want to put a margin around, this is your CTV. So what is contoured here in blue is CTV. But you can see we just put a margin around the vessels because the nodes are all going to be positive around those vessels. This is CTV, and then you would add, what we add is about 7 millimeters. You can add up to 1 cm, but that all depends on what daily imaging that you're using and how well you can localize during treatment. But as you can see, as we go down, it is just around here. You want to just cover the aorta, right? And as we get further down, you don't need to cover out here because the nodes rarely go to the right side. So you just cover the aorta and then the left side because nodes generally come to the left side. So as you can see, we are covering the vessels with some margin. So borders, top of the renal vessels, inferior border of the parotics, the aortic bifurcation, and laterally, if you're going to do 3D, is the transverse processes. So common iliac, we talked about everything drains to the common iliac. The borders are superior aortic bifurcation. This is the most important thing. To cover all your common iliacs, you got to go to the aortic bifurcation. Not L5S1, not L4L5, the aortic bifurcation. And that varies, and I'm going to show you, it varies person to person. So we always go to to cover the common iliacs, we go to the top of the aortic bifurcation. You do not need to cover all the common iliacs for endometrial cancer. You 100% do not need to cover the common iliacs unless you have positive pelvic nodes for vulvar cancer. And I will show you that in a bit. Okay, so inferiorly is the common iliac bifurcation. And again, as you can see, it is margin around the vessels, and the lateral border is going to be your muscle right there. As you can see, it goes right to the muscle, and around the vessels, and again to the side of the muscle. And then we're going to talk about the sacral margin right here, which should be about 1.5 to 2 cms on my next slide. So this is only for 3D. If you're doing 3D, you want to avoid splitting the vertebral bodies because it can affect your complete coverage of the nodes. Now with IMRT, you don't, but it also makes it harder to match. Again, with IMRT, not as important. So the bifurcation of the aorta, as I said, it does change person to person. And in fact, we did a study looking at where the aortic bifurcation fell. And as you can see, it's all over the place. And that's why you cannot use bony landmarks for that. So you need to look to see where that is, and that's going to be the top of your normal pelvic field for cervical cancer if they're node negative. Sacral nodes. This is actually a wrong slide because uterine does not go to sacral nodes unless there's cervix involvement. Sacral nodes are positive if you have cervix or vaginal cancer, and you can see where the sacral nodes fall. In fact, I was part of the initial RTOG guidelines on contouring, and we forgot all about the sacral nodes, and we had to do an addendum on them. But that's the key, is you have to give about 1.5 to 2 cm. And I do, my brush will be 1.5 to 2 cm anterior to the sacrum to cover the sacral nodes. Other thing, mistakes that I see. You do not need to include this notch right here. This is where the nerves are. Your nodes do not fall there. So you do not need to bring it down here. One, you're treating the nerves for no reason at all, but you also increase dose to the bone marrow and you increase dose to the bone that could lead to fractures. So that's probably one of the biggest mistakes I see, because in rectal cancer, you have to do that. In rectal cancer, you have to cover those nerves. But in GYN tumors, it doesn't track. So you do not need to cover those nerves down there. The other thing, traditionally, we would go to S3 for locally advanced cervical cancer. So you would go to the bottom of S3, which is what the slide says. Embrace has changed that to S2. So you do not need to, for Embrace anyway, they're only going to S2, they're not going to S3, we're still going to S3. Internal, external iliacs, everything goes to the internal, external iliacs. And as you can see, again, it's vessels. You got the sacrum. You just need to put space around them. And this, again, is your CTV. And this just shows you your external iliacs, your internal iliacs, your sacrum. See, 1.5 to 2 cms on both sides. So obturator node. This is going to be your uterus, cervix, vagina, and vulva. It always should be included in your vulva if you're going to include your groins, border, laterally, the muscle, and top of the symphysis pubis. That's the most important thing. You have to cover the obturator nose to your symphysis pubis. Again, something that we had to correct on our RTOG guidelines because we did not go low enough. But you can see here's the obturator nodes. Key is once you get to the femoral head, and as these nodes go into the inguinal canal, you can get off. So you do not need to cover over here because that's no longer your obturator node. That is now your inguinal node. So you can see how we come off as the nodes start going laterally, and it's usually at the level of the femoral head. So what are some of the common mistakes? CTV on the muscles, to include bone, to include psoas, and not enough presacral space. And as I said, don't go into the nerves. So how about perimetrium? So this is a good question. This is probably one of the best papers we have on perimetrial contouring. It's actually MRI based, but it does show you where the perimetrium, and it's so pretty. You can actually see this on CT as well, especially if you use IV contrast. When you're simulating, you can actually see it really well. A lot of people believe in using IV contrast to get the perimetrial contours, but the borders are anteriorly the bladder, posteriorly is the perirectal fascia, medially is the tumor or cervix, and laterally is the pelvic wall. So you can see laterally, you're going to go to the muscle, and you can see that. Now, guidelines are different. Embrace tells you to contour the perimetrium separately and then bullion everything. I try to do the cervix and the perimetrium, or the vagina and the perimetrium, as one structure. I think it's up to you to decide, but key is you want to make sure you get the entire perimetrium. Embrace does say do it separately and then bullion. I try to do it all together. Most important for locally advanced cervix cancer is you've got to get the uterosacral ligaments. You can see where this is. Here it is right here. See how it's going posterior, and see where it was. This patient actually reoccurred because we did not go posterior enough. So you've got to make sure you cover the entire uterosacral ligament when you're contouring your cervix and your vagina. So that means you really need to go this posterior. And really what we'll do is we'll cover the anterior 1/3 of the rectum to make sure that we are posterior enough. So vagina, embraces now 3 cms of the vagina from if it's negative vaginal involvement. So we do go to the 1 cm above the obturator foramen still, but Embrace is now actually looking at just the length of the vagina. So if no vaginal involvement, just 3 cms of the vagina needs to be included. If it is vaginal involvement, you want to go 2 to 3 cms below the most distal extent of the involvement. But Embrace has changed that a little bit to reduce toxicity to the vagina. Remember, variations in vaginal cuff, bladder, and rectal filling really make a big difference. We do not use fiducials anymore, but if there is vaginal involvement, especially for vulvar cancer or vaginal cancer or recurrent endometrial cancer, I will do an EUA. In fact, our whole department does an EUA, and we put seeds, either gold seeds, platinum seeds, or titanium seeds, to the distal extent. So we know where that involvement is. So we know what to do when the disease goes away and what to treat with brachytherapy or external beam. And if you're going to do IMRT or VMAP for cervix, remember uterus and cervix also can move. So it's really important to do at least daily, if not weekly, cone beams to make sure your uterus and cervix are not moving out of your field, and again, bladder and bowel or gas, but an introverted uterus could go retroverted. And I actually had a case like this, and I had to re-simulate her to use both. We usually do an ITV, both for the vagina and the cervix. But sometimes for the cervix, I will see if I do full bladder and empty bladder and do an ITV, I'm treating a lot more bowel and rectum. So I may just do full bladder and do daily cone beams, or I may do empty bladder and do daily cone beams. So you have to look. But our normal is to do an ITV for both the vagina and for uterus and cervix. So again, just to talk about 3D, top should be the bifurcation of the aorta, positive. So this is the one time I'm going to say, because we're going to come to this question, one time I'm going to say if you do 3D conformal for common iliacs, you to go to the top of L2. But if you want to include all the paraortics, you're going to go to the top of the renal vessels, not top of T12. You'll see the top of the renal vessels actually probably L1, but you should go to the top of the renal vessels. Inferiorly, obturator foramen, but like I said, embraces doing only 3 cms of the vagina if there's no vaginal involvement. We still go to the obturator foramen. Laterally, 1.5 to 2 cms of the pelvic. Anteriorly, the symphysis, and as we all know, sacrum, embraces saying only S2, we still go to S3. Now, this is a question that was asked. So I'm trying to answer some of these questions. What if you don't have interstitial and you still have perimetrial involvement? So this is all going to be covered when we do the brachytherapy talk, right? You're only going to worry about the perimetrium if there's still perimetrial disease at the time of brachy. So if there's positive perimetrial disease initially, but if it goes away at the time of brachytherapy, don't worry about perimetrial boost, okay? Now, if there's sidewall disease, you may want to come back and boost with external beam if you don't have interstitials. But if the perimetrium is gone at the time of brachytherapy, no need to do perimetrial boost. But let's say you don't have interstitial and there's persistent perimetrial disease that you cannot reach. Then you do the traditional external beam, right? You figure out where the implant is, and you go 5 millimeters from the implant, and you will treat APPA. And you can do this for up to 9 gray. Usually all you need is 6 gray, but you can go up to 9 gray too. So it's just, it's serious at 1 cm superior to the bottom of the SIs. Laterally is going to be your pelvis, right? Inferiorly is going to be the bottom of your field. Medially is 0.5 from your implant, okay? And do it APPA. This is an easy solution. Don't forget, this is okay to do, especially if you don't have interstitial. But remember, it is the disease of the time of the brachytherapy that you're going to treat. All right, another question that was asked. How do you decide when you're going to treat periortics or not treat periortics? This is an important question. Most of our data comes from Embrace. Next, in January, you're going to hear all about Embrace. But they looked at nose at diagnosis. Here's nose at diagnosis. The most commonly positive nodes are in the pelvic area. Where is the failure? You can see 45% is in the pelvic area, but 78% of patients fail in the periortics. So who are those patients? So here is the answer. Risk for periortic nodes. If you have a positive common iliac node, you should treat the periortics prophylactically. If you have 3 or more positive nodes in the pelvis, treat the periortics prophylactically, okay? And this just shows you the high-risk patients are the ones you're going to treat the periortics. And those are if you have a positive common iliac node or 3 or positive nodes. All right. So that was a question that was asked, and I wanted to make sure I showed it to you. And this is data from 2,000 patients. So this is great data. This is data that we can actually use. So next question. You have a patient with FIGO stage 2B cervical cancer who presents for external beam. She is node negative. That's why she's 2B. What is going to be your superior? What's the superior field of your superior border of your field? And as y'all are doing this, just remember everything that I've talked about is for endometrial, vulvar, vagina, and cervix, right? The contouring's all going to be the same. So just remember that.
Okay, we have 84% answering, so I'm ending the poll, sharing results.
So 45% said the aortic bifurcation. That is absolutely correct. That is the answer, okay? As I mentioned, for cervical cancer, you've got to treat the entire pelvis. That includes the common iliac nodes. And it's a node negative patient. So the answer would be aortic bifurcation.
Excellent.
And that's what this shows. Okay. All right. So next thing is questions about dosing, right? So, and this was another question that was asked. And I know the slide is very busy, so I'm going to be, again, you will get these slides. 45 gray for microscopic disease. And this is, again, based on my on Embrace as well. So remember, all of this is Embrace data. Lymph nodes that are grossly involved should be a minimum of 60 gray. So how do we do this, right? And this was a good question. If you have, and I will tell you how we do it, and Embrace does it a little bit different. So let's talk about how Embrace says. Embrace says for positive nodes, SIB, 2.2 for the pelvis and 2.3 for the periordics for 25 fractions, okay? The reason why they do 2.2 to the pelvis is you're gonna have brachytherapy contribution that will give some dose to the pelvic nodes that hopefully will take it to a higher dose, right? So 2.2 times 25 gives you an equivalent of about 55 gray. And then you got to figure out how much that brachytherapy is giving and then decide if you need to boost those nodes more, because you really want to take them to at least a 60 EQD2, combination of external beam and brachy. Okay. My rule of thumb is 2 cms or less, whether it's periordics or pelvis, I will do this. I will take my pelvic nodes at 2.2 gray per fraction and periordics at 2.3. If they're bigger than 2 cms, I usually take them at 2 gray per fraction and resimulate and then come back and give them extra boost. Because as they shrink, bowel falls into that field and I'm overdosing the bowel. So that's my rule. But Embrace 2.2 to the pelvis and 2.3 to the periordics to the gross nodes. You really, at least in the pelvis, you really want to go to closer to 65 EQD2. So make sure you get there. So if you've given neoadjuvant chemotherapy, so let's talk about that because I am going to talk about that trial. If you've given neoadjuvant chemotherapy, you still at this moment in time have to take the nodes that were involved to at least 60. So you have to know what the nodes were. And at least as of right now, we know at least 55 to 60, even if they've completely resolved after neoadjuvant chemotherapy. For post-op, extracapsular extension, you want to go to 60. You want to include lymphocysts if they're extracapsular extension, okay? And in all gross disease, you want to go to 60, if not more. So duodenal tolerances, we actually did, this is important because you are going to treat periordics. We actually did a paper looking at duodenal tolerances, and our current restraints are D55 gray less than 15 cc's and D60 less than 2 cc's. This is a great paper. It shows you actually had a patient who died because she had a rupture of her duodenum because I cured her of her ovarian cancer, but I overdosed her duodenum. So duodenal toxicity is really, really important. So just because we have to talk a little bit about hyperfractionation. As we know, hyperfractionation works great for breast and prostate cancer, has not been used a lot in GYN cancers. The most common fractionation in GYN cancer is really 40 and 15. Again, very little data. So if you guys are doing it in Ukraine and you have data, publish it because we need this. But this is really all that's available right now. Shows that probably 40 gray is a reasonable option, or 44 gray and 15 fractions. And one study that looked at this with brachytherapy, decent results, both acute and a local response. They're planning on doing it with IMRT, but we really, really need more data to show that hyperfractionation works. And this really should be a next big study. We are doing it in post-op patients. And we'll let you know how that goes. But right now, for intact, very little data. So if you are doing it, please publish. All right. Question that everybody asked. So let's talk about interlace for just 1 minute. It's just 1 minute, and then we'll go on to the next thing, right? So interlace. Paper just came out. Well, what is interlace? It is looking at standard chemoradiation with brachytherapy versus carbotaxol followed by standard chemoradiation. Key in interlace, which is different than every other neoadjuvant study, is that the chemo was given every week for 6 weeks. So it wasn't every 3 weeks, it was every week. So it was very intense chemotherapy. And that's very important. Important to know, the other thing important to know in the study is majority of the patients were stage 2, okay? Majority, 70% were stage 2, 58% were node negative, or at least 50% or higher were node negative. So a very low risk group of patients. Majority of them were treated with 3D, external beam. They were all, 50% of them were treated to point A, only 30 or higher, really only 30% were treated with image-guided brachytherapy. Granted, great overall time. EQD2, really important to remember because we are, we're going to talk about this. EQD2, 79 for chemo RT, 80, for induction chemo, and 80 for chemo RT. This is all very important to look at, right? RT, the other thing to remember on this, you give 6 courses weekly. You start the radiation therapy the 7th day or at least 2 weeks later. You cannot wait 3 weeks. You cannot wait 4 weeks. That is very important about the study. What did they find? That it improved overall survival and disease-free survival, right? No difference in local control, really. So where the neoadjuvant chemotherapy made a difference was distant recurrences. Now, the question is why and how? But interestingly, in this editorial, I think everybody should read. It's a great editorial. It's done in the International Journal of Gynecologic Oncology. And what they did was they looked at interlace compared to Embrace. Okay, so what we know about Embrace was all IMRT, and it was all image-guided brachytherapy. Okay, so comparing Embrace, interlace-like patients compared to interlace, you can see that one thing that Embrace did was they did treat the periortics prophylactically, which was not done in interlace because you could not treat extended field. So that's very important. They did give boost that we know for sure to the nodes. But look at this. Look, so EQD2 78, Embrace, the EQD2 to the HRCTV is 90. So definitely higher doses. Equivalent distant relapse rates, equivalent 5 years, and equivalent, 5 years progression-free survival and overall survival. So what this paper says, and what a lot of people say, is if you do good radiation therapy, induction chemotherapy probably is not needed. And that good probably is meaning image guided, not interstitial. So it doesn't have to be interstitial, but image guided, and that you treat the periortics when needed, right? So good radiation therapy probably does compensate for neoadjuvant. But it's important, if you are going to do this, this requires the scheduling to be perfect. Most of these patients got Neupogen, GCSF, to get them through it. And what I'm hearing from people, they're having a hard time getting patients, outside of the protocol, to get their brachytherapy, because at 56 days is still important. So you don't want to delay. And what they're finding is they're having to delay the brachytherapy because of counts. So I highly recommend this article, which is saying is good radiation therapy probably is just as good as neoadjuvant chemotherapy. So most people are not adopting this trial because of that reason. All right, I did not talk about this. This is our third poll question. What is the best way to boost the cervix after external beams? Stereotactic, standard fractionation, surgery, or brachytherapy? That's an easy one. You're going to have this again, I think, in January. Perfect. Look at that.
You're giving away the answers.
I know. That one I am. They're still missing them. I don't know.
No, I think
I
they're
think
doing
they're
very well.
purposely answering them wrong. The rest
Okay.
of it's going to be much easier. Yeah. So I think we got it. So yeah,
Yeah, we
brachytherapy.
got it.
Yes. Great. Okay. All right. We're going to move on. So I'm going to move on to vulvar cancer, because I was asked to talk about vulvar cancer, my least favorite thing to talk about, but treat. I hate vulvar cancer, and I think you've heard this from my RCC talk, because I say that every time I do my RCC talk. Vulvar cancer, we see at least one or two a month in our department, all locally advanced, so not surgically. They represent 4 to 5% of all gynecological cancers. Really important to know. There are two types. There's HPV related and non-HPV related. In the US, we see primarily non-HPV related. They're associated with lichen sclerosus, and they're in older women, and they're radio-resistant, okay? In the rest of the world, if vulvar cancer is HPV related, most commonly associated with HIV as well, and it is very radiosensitive. So it is like the head and neck, it actually responds to radiation. Non-HPV, which is what we see, is very radio resistant. Workup, we've already kind of talked about. EUAs are very important in this case. We always do an MRI to help identify the disease. We will always do a PET scan, but CT scan is just as well to look at node involvement, okay? This is just an example of a patient of mine. And I had a picture, I took it out because I had too many slides, but you can see MRI-wise, she had a lesion right in the labia minora, huge lesion, exophytic. But if you put it together, you can see the lesion right there on the MRI, and you can see it right there on the PET. So the most common site for vulvar cancer is the labia. Okay, then other ones are perineal, mons, clitoris, Bartholin's gland. Bartholin's glands are usually adenocarcinomas. Everything else is usually squamous cell carcinomas. How does vulvar cancer work? Just like cervix, but different, because it goes to the inguinal nodes first, and then it will go to the pelvic nodes, and then the common iliac nodes. So it's either nodes, and nodes are first, or direct extension. And pelvic nodes are only after you have inguinal nodes. You cannot have a positive pelvic node if you don't have inguinal node involvement. Staging has not been updated. Key to note is if you have positive pelvic nodes, it's a stage 4B. But patients with positive pelvic nodes are still curable. They have over a 50% chance of cure. You need to treat patients with positive pelvic nodes definitively. How do you decide how to treat? There's many options. The most important thing that I can emphasize to you right now is you should do a multidisciplinary. This is the one cancer that the surgeons and the radiation oncologists need to come together to decide what's the best way, whether it's surgery, whether it's pre-op radiation, whether it's definitive radiation, or surgery followed by radiation. Lymph node dissection is important. I'm not going to go through that because it's a lot of data, and I'm trying to get a lot in an hour. But, groins show you is mainly sentinel nodes, and you really need to make sure you have negative nodes. So here's really just the management, at least at MD Anderson. If it's resectable, you do surgery, and then you decide post-op radiation. as needed, depending on margin status and node status. Key, again, I'm not going to go through this a whole lot, but 7 millimeters, positive close margin, gone. So Heap's criteria is not important anymore. And what is more important is 1 to 2 millimeters or vulvar in situ around in the margin, but 7 millimeters is gone. Even 5 millimeters is gone. You can observe a patient who has 5 millimeter closed margin. 1 to 2 millimeter margin you want to treat, or positive margin. Pre-op, almost all gone as well. Really, we're moving to more definitive radiation therapy. So what are the borders, right? This is where it is a little bit different. One, you do not need to include the sacral nodes for vulvar cancer. Remember that. That's really important because that's going to save you bowel. Negative groins, you can actually really go below the SI joints. If you have positive groins, you can go probably to L4, L5. You really want to cover the next echelon up, which is the obturator, external, and internal iliacs, not common iliacs. If you have positive pelvic nodes, then you want to include the common iliacs, right? So if you have positive groins, you want to cover the next echelon, which is obturator, external, and internal. So you can go to L4, L5. Do not include the sacral nodes. Key. So IMRT probably is your best bet in this. This is probably the one cancer that's best treated by IMRT because you can protect skin, you can protect central pelvic, central structures like the bowel, and you can spare the femoral heads, and you can give concurrent boost. It is a steep learning curve. You got to know what to cover and what not to cover, and you got to do daily imaging on this because these patients move. This is the one time I use a lot of bigger PTV. So for my groins, I use the CM. Also, even for my vulvar, I use the CM. So how do you simulate? We always do frog leg. I'm going to say I think you should move away from frog leg, but kind of try to keep the legs apart. So maybe put a bar. Nowadays, they have a bar that can keep the legs apart. And then you do a CT scan. You can put bolus. I don't put bolus anymore for my simulation, but then I do use bolus during treatment. We do figure out the dosing before we use bolus, but if you don't, you want to use either 3 millimeter or 5 millimeter bolus, but just cover the disease and not cover the whole area that you're going to treat. So how do you contour? Key is you want to contour the disease. You do not want to cover the mons unless the mons is involved. This is a sagittal view so that you can see the red is what you want to treat. The yellow is not what you want to treat, okay? Here it is again. You want to spare the legs. You want to cover the vulva. Don't cover the mons unless it needs to be covered. You want to go 2 to 3 cms into the vagina unless the vagina is involved. Great paper for everybody to look at. It goes over the consensus guidelines. Again, as you can see here, the clitoris is coming in, but we're not treating the mons anymore. You do not need to cover that anymore. Okay, so like here's the clitoris coming in, right? We're sparing the mons because that will spare, swelling. And you can see, look, I mean, it's just perfect. We get off as we're going lower down, then you're going to include all the vulva. So spare the mons. Another great paper that talks about how much margin to put in, and just key for inguinal nodes, everybody asks this question. Superiorly, it's the inguinal ligament. Inferior lateral is the intratrochanter line. So you can see right here, that's the most inferior part of the groins. Superlateral is the anterior inferior iliac spine, and distally the lesser trochanter. So you can see this is a good borders for your groins. Contouring, really important. As it exits the vessels, it's both anterior and posterior, but once you get out, it doesn't go post the vessels. So you do not need to go posterior to the vessels. All that does is increases the dose to the femoral heads, and it does not help you and increases toxicity because the nodes lie anterior to the vessels. There is no need to extend your CTV past those vessels. Lower, as you can see, look, your CTV should not go past that vessel, but go to the muscle and you go around those vessels. And just cover the medial groin as you go lower down. So what doses? Again, 45. Gross disease to the vulva. If you have gross disease, you want to go to 66. Gross disease to the vulva, 66 is what you need. You can't go higher. Groins, if you have big groin nodes, you can probably take them to 70. But vulva, it's really hard to push past 66. We do an SIB. Normally we do we never go higher than 2 gray per fraction. So we'll take the gross disease to 50 in 25 fractions, and then we'll come back and just boost the gross disease for the additional 16 gray. More than 2 gray per fraction to the vulva, you're not going to get the patient through. I'm just going to say that. But unfortunately, unlike anal cancer, you really need to go to 66 gray to gross disease in the vulva. So you should never give vulvar cancer patients a break. They will get dry and moist desquamation. I always tell my patients, you're going to hate me near the end of the treatment, but remember, it will get better in 2 weeks. And I do use pain medicines. If a patient comes in, and I'm going to show you an example, if a patient comes in 2 weeks into the treatment and their skin looks like this, and you see just redness, 2 weeks into the treatment is not moist desquamation, it is not dry desquamation. 2 weeks into the treatment, you see redness throughout the field, the patient has yeast. Treat the patient with yeast medicine, okay? 2 weeks into treatment, they're gonna come in with this brisk erythema, and people will stop. No, that's yeast. Treat it with yeast and continue the patient onwards, right? So the first 2 weeks, sitz baths, keep it dry. The second and fourth week, you are going to get erythema and dry desquamation. Again, we use Aquaphor a lot. We do use sitz baths, barriers. Dombro works. I put baking soda in the water, and that really helps. It's cheaper than Dombro. Dombro is very expensive. 4 to 6 weeks, you got moist desquamation. Silverdene works great, but I don't use it during treatment. I have them use it afterwards. And then for diarrhea, you use Imodium, right? So here's yeast. For bacteria, treat them with antibiotics. And actually, antibiotics sometimes help. This is the best thing ever. I can't pronounce it, but it really works well in keeping that skin dry and clean. All right, I'm almost done. I'm going to do quickly endometrial, and then we'll be done because we got great cases. But let's do this. This is easy. What's the most common site for vulvar cancers to originate from? Labia, perineal body, clitoris, or Bartlett's gland. And I really have made my endometrial really pretty brief because I knew we were going to get out of it. And we do have some great cases. I really do think you guys are just putting the wrong answers just to make me feel better.
Makes it more fun.
Yeah. Right. So the answer is labia. Correct. You want to just share it. Great. The labia is, and that's where you see most of the disease. All right. Endometrial cancer. It's the #1 cancer in the United States. It's becoming more and more common throughout the world. Most common histology is endometrioid adenocarcinoma, 75%, right? Then the rest is clear cell carcinosarcoma or serous. So what do you need to decide adjuvant therapy? And this is, like I said, I had made it very focused on what we're going to do. And you need the description of surgery, you need to know the extent of the surgery, and you need to know if they have lymph node dissection assessment. So in the United States, sentinel nodes is the #1 thing. All of our patients have sentinel nodes. I think in Europe, node assessment is actually not that world spread, right? And actually all the PROTECT studies, most of the patients did not get a node dissection. That's important. But key, you need to know pathological subtype, grade, depth of invasion, lymphovascular space invasion. ERPR is still important, okay? Extent of disease, and then again, like I said, lymph node assessment. And nowadays, and we'll talk a little bit about this, you do need to know molecular studies. So let's start with early stage. And again, this will fall in a little bit into your brachytherapy, but I'm not sure if he's going to do endometrial cancer. But lymphovascular space invasion is so important, especially if you do not have molecular subtyping or profiling. then lymphovascular space invasion is the most important thing on deciding how you're going to treat that patient, okay? Whether you're going to give cup or whether you're going to do pelvic radiation. And the study, again, came from PROTECT, just showing you that no lymphovascular space invasion versus any lymphovascular space invasion is still prognostic. So when you're looking at patients with early stage, which means stage 1 or 2, you're going to look at the risk for recurrences versus the risk of complication. And then you're going to decide what is the best way to balance it, right? So risk of recurrence is grade, lymphovascular space invasion, age, and deep invasion, okay? Risk for complication, age, bowel issues, right? Extensive lymph node dissection and history of peritonitis. So you're going to look at and balance and decide what is the best way to treat these patients. As we all know, for stage 1 patients, and really a lot of stage 2, multiple studies have looked at cuff versus external beam and found them to be equivalent, okay? So for most patients, early stage vaginal brachytherapy is enough. But how do you know what? This is the ASTRO guidelines that show you on what their recommendation would be for stage 1 and 2. You can see for stage 1A, grade 1 and 2, if there are no risk factors, observation. If there's high risk factors, which include age or lymphovascular space invasion, vaginal brachytherapy, okay? For grade 1A, grade 3, 1B, grade 1 and 2, again, you look at risk factors and you then decide whether you're going to do vaginal brachytherapy or external beam. So let me just show you if you were going to look at it this way. And this is really how we do it. Now we are starting to look at our molecular profiling, but if you had no molecular profiling, this is probably the best way to look at it. So for stage 1 and 2, no invasion, observation. For grade 3, we do cuff. If you're less than 50%, grade 2, we will do cuff if there's lymphovascular space invasion. Okay, grade 3 always gets cuff. Okay, for grade 1, greater than 50%, we will do cuff, whether there's lymphovascular space invasion or not, but this is somebody that you could observe looking at their lymphovascular space invasion. Grade 2, because we get nodes and they're still stage 1, we would just do cuff. But if they haven't had nodes, then you want to look at lymphovascular space invasion and depth invasion and decide if you want to do pelvis, okay? Grade 3, if you have no node dissection or no node assessment, do pelvis. Now, stage 2, if they're less than 50% invasion, no lymphovascular space invasion, grade 1 and 2, you could get away with vaginal brachytherapy. Greater than 50% any grade, then you do pelvic. So most stage 2s, probably pelvic is the answer. All right, so for high risk, I'm going to tell you, this shows you vaginal brachytherapy and chemo. At least in the United States, all high risk clear cell carcinosarcomas and serous get cuff and chemo. That's just a standard now. So more advanced disease. So let's talk about this. So PROTECT 3, as we all know, looked at patients with more advanced disease, and they compared pelvic RT versus chemo RT. And what they found, that there was a pretty equivalent overall survival. There was maybe a little difference in disease-free survival. But they found was that chemo RT did improve failure-free survival, but more in patients with stage 3 disease and patients who had serous histology, okay? So for stage 1 and 2 patients, chemo RT made no difference, but it was stage 3 patients and patients with serous histologies. So this just, I will actually show that in 1 minute. But key was, it improved progression-free survival, but made no difference in overall survival, except in stage 3 patients. So GOG 258 looked at chemo RT like PROTECT followed by chemo versus chemo alone, and found that there was no difference in overall survival or progression-free survival in either arm, but the patients who got chemo alone had a higher risk of pelvic or periodic recurrences. So ASTRO, after all of this, recommended for stage 3 and 4, no molecular, right? All histologies, upfront chemo RT was preferred. So concurrent chemo RT followed by chemo versus, but you could do upfront or you could do upfront chemo followed by radiation, right? So here's, and this is a question I was asked. So let's just stop here for a minute. Let's think about stage 3s and 4s with no molecular. What I think about when I'm seeing my 3s and 4s, is there risk of recurrences higher distantly, or is there risk of recurrences higher locally, right? So for grade 1 and 2, the risk of recurrence is higher locally. So those patients I treat with concurrent chemo RT followed by chemo, right? Patients with serous histology, their risk of recurrence is higher distally, right? Distant. So those patients, I would probably do chemo first and then come back and give radiation afterwards. So I do 6 courses of chemo, I restage, and then I do radiation. Okay, this is with no molecular. So I have to think, so grade 3s fall in the middle. And so then I look at how many nodes are positive, what's involved, and then decide, again, thinking about where are they going to recur first. But serous, if they're 3s and 4s, they have a very high risk of distant metastases. So chemo probably is the most important. They're in the United States, sandwich approach is not preferred. The reason is you're giving chemo, radiation, and then chemo. So what happens? You actually increase the risk of having radio resistance, right? Or chemo resistant, because you're making a break for both. So we either prefer to do chemo RT followed by chemo, or radiation followed by 6 courses of chemo, or 6 courses of chemo followed by radiation. And what we look at is that. That is how I decide what I'm going to do. Another question that was asked, right? But now we have all of this really exciting stuff, poly, low number low, copy number high, and MSI, right? So what is the incidence? So P53 abnormal, 8%, but they have the highest mortality. I'm going to actually, sorry. They have the highest mortality. Non-specific molecular profiling or low copy number variant, 49%, 5% mortality. DMMR, so MMR deficient, 39%. Again, the mortality rate is pretty low, 7.6, and poly, of course, has the best. But you can see the big one is this P53 abnormal, and we just have to look at that, then that's really important. So what is recommended, at least in the United States, are 3 immunohistological, whatever, markers. P53, we do MSH6, MPS2, and then if possible, you can do poly. But this is the 3 that is the most highly recommended in all institutions in the United States. And if you look at the profiling, which is what I was going to say, in PROTECT 1 and 2, it really, as we mentioned, it's the P53 abnormals who did bad, right? So they're the ones who are going to have the distant metastases. And so for early stage, this is actually a study that is ongoing. So for P53 abnormal, it's chemoradiation versus chemoradiation plus a PARP inhibitor. For MMRD deficient, which I'm going to show you why, it's radiation therapy versus radiation therapy plus immuno. For NSMP, chemotherapy versus radiation therapy plus a hormone. And then poly, no radiation. Or it's de-escalation. So this is actually an umbrella study that is actually going on right now. We'll have some answers. But for more advanced disease, again, for PROTECT 3, which is what I wanted to show you, look, and we can look at this. The P53s did the worst, right? The polys did the best. And in between were the other 2. So and these were also the group that actually, the P53 were the ones that actually benefited from the chemotherapy the most. and you can see that they're actually the ones who, so RT versus chemo RT, you can see the P53s actually were the ones who benefited the most for the addition of chemotherapy. The other ones, there really was no difference in the arms. Of course, police did great, right? But it was the P53 abnormals in PROTECT 3 that actually benefited from the chemotherapy. So what about the dMMRs? So we have two studies that have shown that patients who are MMR deficient actually have an improvement with the addition of immunotherapy, especially Pembro, but even the another immunotherapy. So dMMR or MMR deficient patients have shown a benefit with the addition of immunotherapy. And then MMR proficient, really slight improvement, especially with Pembro, but if you saw with the other one, there wasn't that much of a difference. So there might be a slight advantage for the proficient, but there's definitely an advantage for the deficient to add immunotherapy. Just showing you the differences again. So the P53s really did not respond that well to immunotherapy. The deficients did, and the proficient, no difference at all. So this is probably the diagram if you were doing molecular, right? So POLE, no big treatment. If you are P53, probably do chemo. If you're MMR deficient, it should be chemo, RT, and IO. And then proficient, you can decide what to do. So I'm gonna, here we go, right? Okay, so POLE, chemo, sorry, if you do POLE, you don't do anything. If you are deficient, you're gonna add IO. If you're proficient, you may want to add IO. If you're P53, probably chemo RT followed by chemo, or maybe chemo RT plus, depending on what you see. I know this, I'm going really fast, so I do apologize. But let's do this real quick, right? Last question. I do want to stop so that we can go over this. This is a bigger question, but let's do the last poll question. 70-year-old female with endometrial carcinoma involving the polyp. It's a grade 3, no lymphovascular space invasion, but she is P53 abnormal. So how would you treat her? Observation, vaginal brachytherapy plus chemo. What did I say? Or vaginal brachytherapy plus Pembro. And I think, we need a whole separate talk on this. So I kind of rushed through the endometrial cancer one just because it's kind of both external beam and brachy, but we could do a whole separate talk on endometrial. But I really want us to get to the cases. Yes, so you want to share? Do you want to wait? Let's share, right? So the answer really is C is vaginal cuff and chemo because of the P53. So I think the message I want to say is you want to look at the risk of recurrence and decide. But if you're going to use moleculars, deficient MMR, probably need immunotherapy. P53 definitely needs chemo, and whether to add something else to it, but they do not do so well. Proficient, you could do whatever you want, and POLE, we probably are over-treating. Thank you. I'm going to stop sharing.
Oh, thank you so much. That was very, very educational. You went through so much. Quite
Well,
amazing.
I probably went over too much.
No, it was great. And then you answered specific questions that Dr. Sokolovska had. So that was very useful. Thank you.
Yeah, thank you very much, Dr. Jhingran, because I put you a big list of questions, actually, and you did it perfectly. Excellent. Thank you very much for your exceptional lecture. And I have a few cases And additionally, I would have a few specific questions related to these cases, and I hope we can discuss with you about these questions. So first of all, thank you very much to Dr. Jhingran and ASTRO experts for their sharing the knowledge to Ukrainian specialists and to the Help Ukraine group, and especially Dr. Natalka Kovalchuk for the opportunity to have this session and observership and visiting ASTRO and ASTRO. So it's a huge support to us. So my first case, it's a quite young woman, 30 years old, diagnosed with squamous cell carcinoma of the cervix. Her clinical staging was CT2B and 2M0 without a specification of the tumor grade in pathology report. And the FIGO stage, it was 3C2. Last December, she was diagnosed with cervical cancer after biopsy, but she refused to pass any treatment during the year. Of course, during the year, it was progression, and she faced with the evidences of hemorrhage. And as a result, she had severe chronic post-hemorrhagic anemia with the hemoglobin 45 grams per milliliter. And she received a few blood transfusion, and she gets iron supplementation. Disease progression was confirmed via imaging studies, including CT, MRI, PET-CT. And according to the results, currently it's locally advanced disease with secondary pelvic lymph nodes metastasis and retroperitoneal lymphadenopathy. On CT was noted lymphadenopathy of intra-aortic valve, common and external iliac lymph nodes. You can see the lymph nodes involved in lymph nodes on the MRI confirmed, and on MRI it was bilateral external lymph nodes enlarged and more in the right side, bigger one in the right side. And additionally, para-aortic lymph nodes was described up to 21 and 11 millimeters. And the cervical mass was quite big, 52 millimeters on 59 and 75 in different dimensions. And the tumor involves the entire cervix and anterior wall of upper third of vagina. PET-CT again confirmed the lymph node involvement, and sorry, it's changing for the other electricity. So on PET-CT, you could observe the volume of lymph node involvement. It's the fusion result with PET on CT. So it's quite high spread, even upper, less upper than renal vessels.
Can you go back real quick? I'm sorry.
Yeah. Yeah, please.
Yeah. Okay.
On tumor board, we decided to use the next treatment program. It's external beam radiotherapy to the pelvic and para-aortic lymph nodes. In total dose 45 grays in 25 fraction with radiosensitization of cisplatinum weekly. After that, we are going to do MRI of the pelvis and abdomen to assess the response for the possibility of brachy, and further modifications of the treatment. We thought about the boost to the involved this lymph nodes and resimulation. We are going to proceed brachytherapy in total dose from 27.5 till 30 grays in 5 fraction. It's intracavitary brachy because we haven't interstitial. And as the patient quite young, we suggested to her ovarian preservation before initiation treatment. And it was proposed to her para-aortic lymph node dissection because ovarian transposition have to be on this level. And simultaneously consider laparoscopic ovarian transposition. And as option, if she would refuse, post-treatment hormone replacement therapy. And the patient refused surgery, so we proceed with the course of definitive chemoradiation. We started it currently, and as the result, she would have hormones after the treatment. On this slide, you can see the volume of the primary tumor and involved lymph nodes. It's common iliac and para-aortic group. And the total planing volume on the sagittal view with the upper margin of the level PTV L1, it's middle of L1, L2. Patient would be treated with the standard drinking protocol. We treat on VMAT with daily CBCT, and brachy, as we do, it's with 3D CT visualization. Sorry, it's on these slides you could see the dose distribution in 3 dimensions and the DVH histogram. Our constraints were sufficient and according to the NCCN guidelines. Again, we thought about the boost to the involved lymph nodes, and we are going to consider the additional dose 16 or 20 grays in 8 or 10 fraction. It would be sequential boost to the total dose to the lymph nodes 61 or 65 grays. And my questions would be about, first of the question, how would you treat this patient? And what would be the optimal treatment strategies in this case, especially to the lymph nodes? About the indication of the extended field you share with us in the lecture. Actually, previously, it was approach for the para-aortic lymph nodes that we could treat para-aortic region up to the crura of the diaphragm. It's level TH11, 12. Is it sufficient to nowadays, or it's not good? And about the ovarian preservation, if we do ovarian transposition and she had a para-aortic lymph nodes, what decision could be in this case? About PET-CT and other methods you described.
Yeah, so great questions. What a great case. So let's first start off with the ovarian transposition. We personally do not do ovarian transposition. I have to say, honestly, in the United States, ovarian transposition has been really taken out because one, it delays treatment. Two, most of the time when they move the ovaries, it's usually still in the treatment field. So, you know, and they have to clip it, but there's also complications, right? One, only 50% will maintain their ovarian function when they move it. So it's only a 50% success rate. But there's also, you can have torsion, you can have pain, you know, you can have so many other complications with it. So we have stopped doing ovarian transpositions here in the United States. If they want fertility, we will do egg retrievals prior to starting. But again, that delays the treatment by 2 weeks or 3 weeks, right? So we 100% do hormonal replacement up to the age of 50 as recommended by it's the American board, you know, the recommendations to do hormone replacement up to the age of 50. So we do hormonal replacement up to the age of 50. So we are no longer doing ovarian transpositions because of that. You know, so 50% success rate, most of the time is in your field, then it makes it harder for you to treat that patient, and it's not a really great success rate. Top of the field, as I mentioned, for periodics, renal vessels is enough. You do not need to go to the cura of the diaphragm anymore, which reduces the dose of the stomach, right? So up to the renal hilums, unless there's nodes above. Key is you want to be one full vertebral body higher than your positive node, right? So if you do have a node that's pretty high up, then you want to go up one full vertebral body. But otherwise, to treat the periodics, it is the top of the renal vessels, right? We do not do surgery for lymph nodes, but you know, we do a PET scan. Again, by doing a lymph node dissection, you're delaying treatment by at least 2 to 3 weeks because the patient needs to heal. But you know, surgery and resection of the nodes there is not wrong. It just does delay and it could cause complications. A CT scan, a good CT scan with contrast, especially if you did chest, abdomen, pelvis, could replace the PET CT, but you have to have a criteria, which we didn't talk about, right? So Interlace used 1.0 cms as how you identified an abnormal lymph node. Keynote, which we didn't talk about, right, which is the immunotherapy trial, uses 1.5. So I think the standard would be anything that's on a CT scan, anything that's bigger than 1.1 cm and is not symmetrically round, right, or doesn't have a fatty hilum would be considered a positive node. So I think a CT scan is great. PET scan's always better, right? But CT scan is great for lymph nodes, but you have to have this strict criteria on what's going to be considered abnormal. And you really have to decide if it's going to be 1 cm or 1.5. They both studies, you know, debate that. I personally would go with 1 cm or bigger, but you have to look at how that node looks.
Yeah.
I think we covered, you know, when to cover the periodics. Any other questions about this?
And how would you treat this patient? Maybe you have other thoughts about it.
Yeah, that's it. So that's a good question. That's where we went back. And can we go back to seeing how the nodes were how big?
It's quite big.
Yeah, those are big nodes. So I would do exactly what you did, right? Because like I said, if it's 2 cms or less, then I do the concomitant 2.2 and 2.3, right? But these are huge nodes. So I would do exactly how you did. I would have taken that at 200 a day while taking everything else to 45. And then I resimulate and give an additional boost to taking it. That node I would take to 65. So 100% agree with exactly how you did this.
Okay, so the sequential boost up to 65 grays would be better. Okay, thank you very much.
Yeah, I 100% agree with how you treated this patient.
Okay, thank you. And the next question, the next case about the cervical cancer as well. It's the woman 45 years old, locally advanced cancer again, CT 3B and 1M0, and poorly differentiated, figure stage 3C1. Her cervical lesion extending to the parametrium and invading the lower third of the right ureter. associated with the right hydronephrosis and nephropathy. And it was confirmed metastasis involvement of the left common iliac lymph node. PET-CT corrected us that it was bilaterally active lymph node mass in iliac. And before radiotherapy was performed percutaneous nephrostomy, performed to manage right-sided obstructive hydronephrosis. And on this CT, you could observe how it's visualized hydronephrosis, but it's bilaterally, and external lymph node in the left. And the field of the treatment, it's PTV on the in right slide in the lower right corner. So our treatment plan was definitive radiotherapy to the pelvis, in total dose 50.4 grays in 28 fraction, again with radiosensitization, cisplatin 5 administration per course, and without interstitial brachy. It's dose distribution, dose volume histogram for the first course, and as we need to treat the parametrium and affected lymph nodes and the region of the right ureter. So we decided to have additional boosts. One of the parametrial boost, and it's 10 grays in 5 fraction, and after that sequential boost to the involved lymph nodes, 6 grays in 3 fraction additionally. And after that it was brachy boost, 11 gray in 2 fractions. It's intracavitary with Fletcher type. So in AQD, total dose was to the primary tumor 74 grays, to the parametrium and affected right ureter 67 grays, and involved lymph nodes 66 grays. We always do interim MRI when we finished external beam radiotherapy to analyze would the patient be sufficient for the brachy or not. And on MRI, we saw that pre-chemoradiotherapy volume of the tumor, primary tumor in cervix, were 58 to 51 millimeters, and after the all boosts, pre-brachy, it was only residual tissues components up to 10 millimeters in diameter, with deepest invasion up to 9 millimeter into cervical wall. In conclusion, the patient on follow-up the 6 months after the finishing radiotherapy, and there is no pathological signs in the pelvis currently. And I have additional few questions, again, about the treatment course, about the boosts, because we haven't interstitial brachytherapy. About the parametrial boosts, you told us in the lecture, and the correct contouring guidelines again. Maybe you could give us additional advice how we could correctly combine EBRT and intracavitary brachytherapy to ensure optimal outcomes, because it's always we have the fragments that we could have overlaps in the matching the external beam dose and the brachytherapy dose.
Yeah, you know, so can you go back, just so I understand what you did? Go back one more slide. So you boosted the cervix, perimetrium, and the nodes for another 10 fractions. So you
Yeah,
took the cervix to 55, right?
yeah.
Why?
Because we did the brachy in the central tandem only for the residual tissues,
So
because
you
the
didn't, but so
parameter was clear after that.
okay, I guess, okay. So, okay, I guess I'm very confused. So just real quick, when you did your MRI, did you do your MRI after the 10 gray, after the 55, or did you do the MRI after 45 gray?
After the boosts with parameter.
Okay. All right. So I guess we would do, so one, so let's talk about, what I didn't talk about, because we didn't talk about brachytherapy, we always do an MRI our 4th week of treatment as well. So before our brachytherapy, we always do an MRI, right? So that will help us decide, you know, what type of implant we're going to do, whether it's going to be intercavitary or interstitial. So we always do exactly what you do, right? But you know, we tend to believe, which is what Embrace believes, even without interstitial, that intercavitary works, right? And the problem is by increasing your dose to the external beam, you reduce the dose with the brachy. So, right, so you're increasing your dose to your rectum, your bladder, and all of that. So Embrace really believes, which is what we believe. So we would have not, so let's take, so we have interstitial. So let's pretend I don't have interstitial, right? So go back to the next slide real quick. So
yeah, it was only 2 fraction of brachy. So we calculated all those from this boost and those to the rectum and to the bladder. The rectum doesn't exceed 74 grays and bladder 78 grays. So
and you
calculate
use,
this.
yeah. Did you use the ABS EQD2 sheet to make sure you got the right dose?
Yeah. We transfer all doses to a QD2 and calculate all these doses.
So I guess we personally would not have done an external beam boost to the cervix. So we would have just done an external beam boost to the perimetrium because you still have perimetrial disease, right? And we would have treated the cervix with fractionated brachytherapy. So, we would have done, 4 or 5 fractions of brachytherapy. And we usually do between 4 or 5. So we do either 7 gray times 4 or 6 gray times 5, depending on response and what our normal tissue is, right? And we do it twice a week. That allows for you to have regression of the tumor. So I personally, and pre-interstitial, we would have come back and boosted just the perimetrium and still treated the cervix with intercavitary, right? And we would have done probably 4 or 5 fractions to the intercavitary, which I think would have given you the same results, but given you, a higher dose to the HRCTV and to the cervix, probably, than doing it with external beam, because your primary tumor is only getting 74, which is not. You want to, with such a big tumor that it was, you want to get a EQD2 of close to 85, and if you look D2 of higher than 85, or even a point A of higher than 85. So I'm a little bit worried that you have, yes, your rectum and bladder are all within tolerance, but you probably have given a lower dose to the primary tumor. So what we would have done is definitely boosted the perimetrium with external beam, probably that APPA, that's what we used to do before interstitial. Or you can contour and do it with IMRT, right? And I've shown you how you can contour the perimetrium, but you do need to get the dose. That's why it's good to do the brachytherapy at least once, so that you can figure out what the dose distribution of the brachy is, so you know what the medial border of your perimetrial boost would be, right? So we would have done 1 brachytherapy fraction, and then come back and matched the medial border of my perimetrial boost to that brachytherapy contribution. Does that make sense? Because what I'm
Yeah.
worried about is not the dose to your rectum and your bladder, it's the dose to the primary tumor, which is probably pretty low for a 5 cm mass. You probably needed to get to a primary tumor of at least 85, and that's my concern with that. So we would have definitely done the brachytherapy as well as a perimetral boost, but we would have done 5 fractions and treated the cervix and not treat the cervix with external beam.
Okay, thank you. It was an option for the quite big tumor as we saw in this patient, and it was our decision for this case.
Yeah, I mean, the recommendation is to go to 50 and then see, because some tumors are very slow in responding as well, right? And they could take time. And as you do the fractionated brachytherapy, they're going to decrease in size. So, my big concern is really that it is the EQD2 of the primary tumor, which is a lot lower than, what is recommended. But hopefully, I mean, you've had a great response, so maybe she'll be fine, right? So everything, you have to do what you can, but that's what I would have done, is just done the brachytherapy a little bit more fractionated and boosted just the external beam and then, the perimetrium and the nodes with external beam.
Okay, thank you. The patient under the follow-up, and we will see the results further.
Yeah. Fingers crossed. I mean, she's had a great response. I mean, so we'll just fingers crossed, and hopefully she will do well. But that's the recommendation, would be just to do the brachytherapy and come back and do more fractionated brachytherapy and get an EQD2 to the central tumor of at least 85.
Okay, thank you very much for your recommendation. Thank you.
Thank you. Great cases. Thank you so much, Dr. Sokolovska, and a great discussion. So we have some questions in the chat. So one question is, thank you both speakers, great cases and excellent lecture. When do you recommend to make molecular testing? In what stage? Because it's expensive to do it.
Yeah, no, and that's a great question. I think it's histology, not, I think if you have serous carcinoma, I would do at least a P53, no matter what stage. And then for stage 3, then I would do molecular testing. But for stage 1, unless it's serous, I would, and in serous, I would only do P53. But for stage 3, I would do molecular testing, because the IO really does make a difference in stage 3 patients.
Okay, thank you. And thank you for excellent talk. That's a question from Olena Marcenius. My question is there any option for vulvar EBRT irradiation, re-irradiation?
Yeah, so that's a great question. Very good question. That's why we do take our vulvas to 66 gray GTV. Re-irradiation is really tough in that area.
Yeah.
India has a big study where they're actually using brachytherapy for local recurrences and have had excellent results. So they are re-irradiating using interstitial brachytherapy and have had great results. Otherwise, it's really difficult to re-irradiate in that area because of, skin doses and all of that. But India does have, they use a lot of brachytherapy, a lot of interstitials as their boost for their vulvar cancers, and they will use interstitial for re-radiation, have had a good success with that, but you have to be very experienced in doing that.
Yeah, great. Is there any dose restriction for the iliac artery aneurysm?
No.
If it's in the PTV? No.
Not at all.
Okay.
Not at all.
I wanted to ask you also a question about dose constraints. Do you spare bone marrow, low doses to bone marrow?
No, because
you don't
the
worry
data
about
really
it.
shows it really doesn't make a difference, and all it does is increases the dose of the bowel, right? So we are not doing that, and I don't think it makes. Now, you know what? If you use neoadjuvant chemotherapy, it may make a difference because you need that bone marrow, but I don't think so. And most people have moved away from that. It's time consuming. It really does not improve.
It's really actually challenging to achieve these constraints. So I was wondering how you deal with it, or you don't do it. Okay.
Got it.
Okay, and you mentioned the hypofractionation study, right? Are you working with someone in LMICs to maybe guide them and start them with the study?
So that's a great question. In fact, we are looking at in Uganda for their data.
Okay.
Like I said, if you
Uh-huh.
guys are doing it, we need data. But we are doing a hypofractionated study for in post-op cervix and endometrium here in the United States. So it's
Mhm.
being done in Chicago, Utah, and us. And it's for
Mhm.
cervix and endometrium. But, you know, this is a study that needs to be done. We just need to do it. It's just we don't have any data on it. So it'd be great to do a study like,
So are you willing to collaborate
yeah,
with maybe Dr.
100%.
Sokolovska?
Yeah, 100%.
I would like
Oh, that would be great. That would be amazing collaboration. Dr. Shepil, Dr. Sokolovska.
Yeah, and what we just have to figure out is how to give the chemo, right? That's the biggest question in attack cervix. That's why it works in post-op, because you can do that and then give systemic chemo. So we just have to figure out how to get the 5 courses of cisplatin, but I think it would be a great study and we need to do it. I mean, it shows great benefit in prostate and in breast, right? There's actually less toxicity using hypofractionation. So it would be great to do it in cervix.
And it's very important for LMICs to do hypofractionation. They can increase capacity, so that's very important. That's great. I would like to invite people, if they want to ask a question, turn on their microphones, cameras, and ask. In the meantime, I'll just ask you a visionary question. Where do you see GYN cancer care with radiation going, or maybe overall GYN cancer care going? What are you excited about in the next 5-10 years?
Yeah, okay, so that's really interesting because I'm a little bit worried about GYN cancer care because it seems like IO is going to cure all cancers, right? So the study that I didn't talk about was the keynote study for cervix cancer. So as we know, we talked about interlace because that's what we was asked about, but the keynote study shows that, you know, IO added for stage 3Cs with PD-L1, but you don't have to be PD-L1 positive. It actually improves survival. So our standard now for our stage 3C1s, more than 2 or 3 nodes, and our 3C2s are all going to get chemo RT followed by followed by IO, like keynote. Not chemo, right? But by IO. So for our stage 3C1s, more than 2 nodes or more than 3 nodes positive. Because in keynote, the patients had 2 or more positive nodes to get on the study. So for more than 2 positive nodes or positive periodics, they're all going to get chemo RT followed by IO and IO with the radiation. Okay. So I'm afraid that maybe IO is going to replace you know, I don't know.
Replace radiation? That's
yeah.
the
But I think image guided and the way we're going is the right way to go. I think we're improving quality of care of our patients, and that would be my goal, is that we improve image guidance and decide who to treat, what to treat correctly, and improve the quality of our lives of lives of our patients who are so young right now.
Right. Yeah. Thank you so much. I don't see anyone raising their hand to ask questions, so we'll say thank you very, very much, Dr. Jhingran, Dr. Sokolovska. It was a very excellent lecture and case review and discussion. And see everyone in 1 month. Bye, everybody.
Hey, everybody. Have a great
Thank
day.
you. Thank you.